I'm going to do a brief overview of ACLS. I'm going to go through some algorithms in a quick format with you guys, and some of this information you may find on the test. So I want you to be prepared for that. All right, so what we got going is on this screen is you have our tachycardic rhythms. So I'm basically going to start with our live rhythms, and I'm going to show you an easy way to go through this. So that is the algorithm that you see on your screen. And this will focus in on you. So what you see on your screen is going to be the algorithm. And that'll be a sheet you guys could have and carry. It'll be on the fold out cards when you guys look in your ACLS. I'm going to show you my version, which is a little bit different. So what I'm looking at is different type of rhythms. And I have basically in my mind, 3 rhythms. I have my fast rhythms, which you can't see that. So I'm going to pop up here. I have my fast rhythms. I have a slow rhythm. And then I have my non-perfusing rhythms. So let's see how well you guys can see that. I know it's focusing in and out, but I want you to start with the fast rhythms. So basically fast, in my mind, is greater than 150. Realistically, we're up closer to the 180 mark, but sometimes ventricular tachycardia can be in the 150 range and above. So I want you to consider fast rhythms are 180 and above, or obvious wide deformity. So when I look at a fast rhythm, big things I want to know is it wide or is it narrow? Hopefully you can see that. And when I'm talking wide, I'm talking greater than 0.12 is wide. So is it wide or is it narrow? You guys should be able to look at this and be able to tell real easy. My next thing I want to determine is my patient stable or are they unstable? So I can have an unstable patient, or I can have a stable patient. And I define stability in 2 ways. 2 ways, well, technically 3 ways. 1, hypotensive. So is their blood pressure less than 90? Hypotensive, unstable. 2, altered level of consciousness, in and out of consciousness, dizzy, slow to respond, completely unconscious. That's unstable. And 3 is substernal chest pain. So it is here. It's not when I push on it. It's not a pressure. It's substernal chest pain. Those are my 3 criteria for stable or unstable. So if my patient is stable, what do I have to treat with them? Well, I've got medications, basically drugs, or I have electricity. If I'm stable, I've got time to play. If I'm unstable, I got to go to the electricity quick. So if I'm stable, I'm going to do drugs on this. So if I'm wide and stable, I've got 2 things that I can do. I can consider using adenosine, 6 milligrams, if I feel that the rhythm may not actually be VTAC, but it may be something else. So that's all I want you to do right now. We're just going to consider that. But my treatment for true VTAC is going to be my amiodarone, and it's going to be 150 milligrams diluted, given slow, over 8 to 10 minutes. Okay, so I don't know how well you can see that, but you at least heard me there. So hopefully you're taking some notes and drawing along with me. Now, if my patient is still stable, but it's a narrow rhythm, what am I going to do there? Well, here I can do vagal maneuvers, because I'm always going to do the least invasive first. If my vagal maneuvers don't work, I can do a rapid IV push of 6 milligrams of adenosine, followed by 12 milligrams, followed by another 12 milligrams if I call medical control, my patient is better. If I do have an irregular unstable rhythm, so I am on atrial fibrillation, only on atrial fibrillation, I can use a calcium channel blocker to stop that, which my calcium channel blockers, the biggest one I want you guys to know is diltiazem. and that's what we use. But that's only for atrial fib. So that's just for atrial fib. It's not for SBT in general. Okay, so that's my stable patient, how I do it. Now, if my patient does not respond to my stable treatments, or if they become unstable, now what do I use? Obviously, I got to be fast, so I got to use electricity. The form of electricity I'm going to use, because I've got 3 of them, is going to be cardioversion. So I'm going to immediately do stacked shocks and cardiovert my patient until they convert to another rhythm. So what do I use joule-wise? Well, VTAC, it's 50 to 100, SBT is 100, SBT is 50 to 100, VTAC is 100. So where I'm going to start? I'm going to start at 100 joules, and I'm going to use escalating doses of stacked shocks of cardioversion until I get a conversion of rhythm. That's it. The only thing I may do is I may sedate them to basically take away some of the pain. But really, all I have to know is my rhythm was fast, greater than 150, greater than 180. Is it wide or is it narrow? If it's wide, are they stable or unstable? And that's what I'm doing. I don't care. If it's fast and they're unstable, doesn't matter if it's wide or narrow, right? I'm doing the same thing. I'm cardioverting, and this is a patient with a pulse. Okay? Simple as that. All right. So on my screen next door, you guys were looking at, you guys could follow it down, follow this pattern on here. Let me have set here. You can see my arrow on the screen. So just follow this area. It'll tell you if it's wide, if it's narrow, different things that you'd be doing. This is another version you can go down. So look at that as well. All right, so my other aspect that I can go is my slow rhythm. And I actually only have one slow rhythm, and this is bradycardia. So bradycardia, what we have to find out is my patient symptomatic or not. So I can have a patient with a 50-degree heart rate who is completely stable and they're not symptomatic. I don't do anything with them. We just monitor and check. But if my patient is symptomatic, basically meaning they have hypotension, they're diaphoretic, they're pale, difficulty breathing, chest pain, anything associated where they have symptoms associated with the bradycardia, then I'm going to treat it. So how do I treat bradycardia? Well, first thing that I'm going to do is atropine. And I can give 0.5 milligrams of atropine. And I can give that every 3 to 5 minutes for a max dose up to 3 milligrams per patient. But if I'm going to use atropine, if I see effect on the first one, probably going to do it again. If I don't see effect on the first one, I might be moving to another aspect. Atropine is only designed for bradycardia and for low-degree heart blocks, like a first-degree heart block, it would be working. Second-degree heart blocks, type 1, type 2, and a third-degree heart block, atropine is probably not going to work, so I'm probably going to want to move on to my next phase, which is transcutaneous pacing. So if I have an indication for pacing, it's probably going to be second-degree heart blocks, third-degree heart blocks, and those patients who have had triphasic blocks going into a cardiac arrest, anything like that where I've got to maintain them. But second-degree type 1, second-degree type 2, third-degree heart blocks, all those are going to be aspects of getting my patient to be pacing, besides what Dr. Raby taught to you in your pacing lecture. Maybe important to know. If pacing does not work, you guys know how to do pacing, you watched my other video I showed you, then I have the options of using my pressors, which is basically either a dopamine drip or an epi drip. And the big thing I want you to know here is one is weight-based, 2 to 10 micrograms per kilogram per minute, versus epi, which is 2 to 10 micrograms per minute, according to AHA. That's it. 3 things I do: atropine, pacing, or pressor drip, dopey or epi. So pretty simple, pretty straightforward. Then I have, I'm going to take this over here. If you look on the screen, once I find, this basically kind of goes through the same areas here. Again, if my patient is stable, does not show any change, I'm just going to monitor and observe. If my patient comes unstable, here's what I'm going to do. I'm going to do my atropine. If that doesn't work, I'm going to consider transcutaneous pacing, or I'm going to do my drips, and then going to consider extra consult. And here's my dosages right over here. Pretty easy, pretty straightforward. Okay, so we're getting better. We're getting down to the last ones here. So let's look at my non-perfusing rhythms. And in my non-perfusing rhythms, we have asystole and PEA. Now, I've told you my thoughts on asystole and PEA, which is basically they are not the same rhythm. But according to HA, we treat them the same way. So my non-performing rhythms, if I have asystole or PEA, difficult one right here, I am going to do, they have no pulse, CPR in 2-minute cycles, and I'm going to do 1 milligram of epi, 1 to 10,000, every 3 to 5 minutes. That's it. So if I come over and we look on our area, what are we going to do? We're going to do CPR. Is the rhythm shockable? No, because if it's asystole or PE, it's not shockable. I'm going to do my 2 minutes of CPR. I'm going to do my epi every 3 to 5 minutes, and I'm going to consider my advanced airway, get capnography on, and I'm going to keep just going around in this cycle. Just going to keep going. If it becomes shockable, now it's no longer asystole or PEA. Pretty straightforward as far as that goes. All right, but one other thing that I do want to talk about that's a little bit different is going to be my H's and T's. So I mentioned that slightly to you guys of different H's, different T's that are going to be out there. So here's where I'm going to bring this one over here and come over there. So this happens in all rhythms, all algorithms we consider this, but especially in PEA. So especially in PEA, we want to consider our H's and T's. So here they are: hypovolemia, hypoxia, hydrogen ion acidosis, hyperkalemia, hypokalemia. We're just going to keep those, probably go down into one. Hypothermia and hypoglycemia is what got removed. So I'm going to consider it. So these are H's I want you to be considering. Hypovolemia, we're going to fix with fluids. Hypoxia, we're going to fix with oxygenation, definitive airway. Hydrogen ion acidosis, we're going to fix with sodium bicarb. Hyperkalemia, sodium bicarb. Hypokalemia, we're not going to fix. Hypothermia, we're not really warming our patients at this period of time unless they are truly hypothermic. We're going to warm up to an area, but we're actually keeping our patients targeted temperature managed right now. And hypoglycemia, if we see that, we're going to be correcting blood sugars. Our T's, I want you to know these well, toxins. So our toxins are basically like our overdose. Did they have a calcium channel blocker? We're going to give them calcium. Did they have a beta blocker overdose? We're going to give them glucagon. Did they have a tricyclic overdose? We're going to give them sodium bicarb. We're going to talk about whatever the overdose is. So they give Narcan. Again, I told you my thing, but opioid overdose. We can consider Narcan to reverse if we want to do that. Cardiac tamponade. The symptoms from there. What are we going to do that? Pericardial centesis. Tension pneumothorax. What are we going to do that? Dart the chest. Thrombosis. So these were built in the thrombosis coronary. We're going to talk about doing 12 leads or suspecting that for an MI. Whereas thrombosis in the pulmonary system is going to be the PE, and we're also going to talk about how you can identify a PE besides history on a 12 lead, and we're also going to talk about inside ultrasounds. And last one is trauma, any type of traumatic injuries from there, what we're going to do. So those are the H's and T's, and I do want you guys to know those. Stop the screen on that page if you want to and go over those H and T's again. All right, last but not least, we have our cardiac arrest situation, which is basically ventricular fibrillation. So again, this one you're going to do CPR every 2 minutes. You're going to do epi every 3 to 5 minutes, consider an advanced airway, and you're going to do a shockable. Is the rhythm shockable? Yes, it is. You're going to shock it. So, but here's how I want you to know VFib. You guys don't know if you can see this on here, so I'm gonna write down low and come across. So first thing I wanna do is I'm gonna start CPR. CPR in 2-minute cycles. I'm gonna put pads on, and as soon as I get the pads on, I'm gonna charge my monitor and I'm gonna look, is it shockable? If that's 15 seconds, great. I don't care. There's no such thing as witnessed arrest, non-witness arrest anymore in this concern. I don't care if they've been down for 10 minutes. If you get a shockable rhythm, we shock them right away, and then our 2-minute cycle starts. So CPR until we get the patches on. Once we get the patches, if it's shockable, we defibrillate. So we'll defib our patient. As soon as we're done with that, we're going to go to CPR for 2 minutes. And 2-minute cycles. During that time frame, did the defibrillation convert our patient? We don't know, right? So we're going to wait till we're done with our CPR. During this time, we'll probably get our IV access, airway, everything else taken care of there. At the end of that 2 minutes, we're going to check for a pulse. If there's still no pulse, and it's still in that shockable rhythm, VFib or pulseless VTAC, we're going to defib again. Notice I'm not putting joules down. We're going to defibrillate again. We're going to go right back into CPR for our 2-minute cycles, and now we're going to do our 1 milligram of epi, 1 to 10,000. At the end of that 2-minute cycle, still in VFib, still no pulse, we're going to defib again. Once we've defib, we're going to go right back into CPR, and now we're going to add our 300 milligrams of amiodarone. Put amio. End of 2 minutes, no pulse, we're going to defib again. We're going to go right back into CPR, and now time frame will be past our 3 minutes in this 2-minute cycle. We'll add in our 1 milligram of epi again. So basically what we're going to do is we're going to alternate now every other defib from epi to an antiarrhythmic. So we're going to defib again. We're going to do CPR, but now we're going to do our 150 milligrams of amio. We're going to defib, CPR, and epi. Defib, CPR, and another anti-arrhythmic, which could be lidocaine, could be something else. So I want you to get those cycles down. Those are my quick, fast, easy area to get this done. Should be simple. You guys may see this in written format on Monday in some component of this. Be prepared. Have a good weekend.